joined now by Dr. Johanna Takkenberg from Eramus Medical Center in Rotterdam. Johanna, thanks for joining me. So, you know, you're obviously well versed in a lot of things in cardiovascular surgery and cardiovascular medicine. What's happening with bioprostheses? Do we have new bioprostheses on the horizon?
Well, right now what I'm observing is that we have a lot of really good bioprostheses, but there is little major breakthroughs going on right now. I think at the far horizon, the biggest breakthroughs are going to be tissue-engineered valves.
Tissue-engineered valves.
Yeah, but until that time, that's still very experimental. We're dealing with the limited functionality of the current bioprostheses, which have evolved over the years. But right now, we're at a point where we're saying, what else can we gain for our patients? And I think the biggest thing that's going to happen in the next couple of years is that we're going to better tailor our treatment to our patients and no longer focus on what is the best bioprosthesis, but on what is the best bioprosthesis for this particular patient.
Tell me, that's an interesting concept. Tell me what you mean when you say for this particular patient.
Well, I think from a cardiothoracic surgery point of view, we've always been taking the concept of bioprosthesis from an engineering point of view.
Right.
And what we're observing right now is that a lot of bioprostheses are performing quite well in a lot of patients, but there may be particular aspects of certain bioprostheses that may do even better in particular subsets of patients.
So tell me, what do you mean by the right bioprosthesis in the right patient?
What I mean is that we have to take a closer look at the patients in whom we're implanting these valves. So a lot of bioprostheses perform very well in the majority of patients, but there are particular bioprostheses that may do better, for example, in young adult patients. Young adult patients have an active life normally. If you're a woman, you may want to have children.
Sure.
And then a mechanical prosthesis is not such a good thing to have. Nevertheless, a lot of our surgeons are implanting mechanical prosthesis. And I think that if in these young adult patients, as an example, if you offer them the opportunity to think about bioprosthesis and think about the fact that they may and probably will require a reoperation later in life, that a lot of them may say, okay, I'll choose that option because of the fact that I live my life right now and I want to live it unrestricted. And that's the crux that we're talking about is we as physicians, we think about disease and the valve, and patients think about their life.
Quality of life, absolutely.
And they're like, oh yeah, there's this problem with my valve as well. And I think if that mindset is going to change in the next couple of years, and if we apply these technological great valves in a way that really is tailored to our patients, I think we have a lot to gain.
I mean, it's very stimulating, the thoughts. Do you think that some of the, you know, because the longevity is certainly something you're alluding to in the tissue prostheses, you were alluding to tissue engineering and that sort of stuff. Is that a reality? You think we're going to get to where we can develop valves that will last for quite a while?
I think so, and I think that's in particular true for young patients, for children and young adults. Those patients where the regeneration capacity is still quite high, so you can think of scaffolds that actually attract stem cells of the patient and that will then grow into a real valve that is the patient's valve. Of course, that's a wonderful concept that's coming closer and closer, but that's the farther horizon that we're talking about right now.
The concept of you know, at least in this country for aortic valve procedures for AS primarily, people, and of course that's an older age population, but everybody's moved rapidly to bioprosthesis because of valve and valve concept.
Yeah.
If you have a younger patient, is that still going to be a lot of people's thinking in the back of their mind that they might tell the patient?
Absolutely. Well, actually, we just performed a survey in surgeons in the Netherlands, cardiothoracic surgeons, and a lot of those surgeons are already conveying that message to their patients, saying this may be an option in the near future. So if you pick your bioprosthetic valve carefully, and it calcifies in a nice way, making it a positive thing, it may be a very good option to put in a transcatheter valve at a later point in your life.
Let me flip the other way and say, so if they develop a mechanical prosthesis that doesn't need vigorous anticoagulation but just antiplatelet therapy, does that change the game for tissue valves versus mechanical prosthesis?
Yeah, of course it will cause a shift for particular patients. But you should not forget that also if you receive a mechanical prosthesis, your risk of a reoperation is not zero. On average, 5 to 10% of patients will require a reoperation later on in life due to pannus or endocarditis or other problems.
Yeah, you're exactly right. No, you're exactly right. That's why I was raising that question. So if you looked out, so let's go 20 years in the future, okay? If we have 100 prosthetic valves put in, and obviously it would depend upon patient's age, do you think the vast majority of them, 90 plus, are going to be tissue prostheses?
I think we're heading that way.
You're heading that way for multiple reasons.
Yeah. And it has to do with the tissue engineering valves that are really emerging right now. And if you combine that concept with transcatheter delivery, that would be even more exciting, of course. Of course, not good for our specialty, cardiothoracic surgery. But we'll have to adapt to that.
And you are adapting to that. But I think your concept, I love the message that you gave, and I think it's a good way to end of this concept of really getting the patient engaged in the discussion.
Yeah, I think that's crucial at this point in time. And we're developing actually tools to do so, internet-based tools, apps for your PDA, and in a way and in a language that patients can comprehend, and also tailor to their needs, because they don't care about patient prosthesis mismatch and all those technical factors.
That's great. Are you all developing it at Eramus, or as a society you're developing it?
The Dutch Society is actually developing a tool for Dutch patients.
That's very good, because it's very hard, for patients to understand it. In fact, a lot of young cardiologists don't really understand, the differences in the valves.
Yeah, I remember.
Okay. Thanks for joining us.
Well, you're welcome.
Good. Thank you.
Yeah.